Welcome to Take Charge Live. Ask Me Anything, an hour of questions with the doctors. I'm Melanie Barron, and we're very glad that you've joined us tonight. Tonight's topic came about because on almost every previous episode of Take Charge Live, there has been somebody who has asked a question that has had nothing at all to do with the topic, but they just see this as an opportunity to get that question in. And I can't blame them one bit. I would do the same thing. So we decided to do an entire episode with no presentation. You guys are the subject, and any question you'd like to ask, no judgment. We will answer it as honestly as possible, and the doctor's time is your time, split with their wine and cookies, of course. So it is my pleasure to introduce the doctors of Memory and Movement Charlotte. Right now, we have Dr. Sanjay Iyer and we have Dr. Aris Chaconas, both of our neurologists. Dr. Chaconas is our memory neurologist and Dr. Iyer is our movement specialist. And we are still waiting for Dr. Edwards to join us. He actually left the office for a bit and hopefully he's going to get back in time. So I do hope that he'll join us. He certainly intended to join us and I expect that he'll show up. So I'm going to unspotlight me and spotlight the doctors who are here. And remember, when you have a question, turn your microphone on so we can hear you. Or if you put it in the chat, we've got quite a collection already started. We thought we were going to have to prompt you with some canned questions, but I don't think we do. All right. Do we want to start with something?
This sort of reminds me of the time that I signed up to sit in the dunking booth.
You never know what you're going to get. So there are some questions already in the chat box. And why don't we just start from the top? Actually, why don't we start with something a little bit humorous? Can you tell us the best question that you've ever been asked outside of the office?
You mean as a physician?
Mm-hmm. Like who's come up to you in a men's room somewhere and said, hey, this thing right here, can you take a look at this thing? Have you had any of that?
I've had that quite a bit. And it usually is a skin abnormality, a skin lesion. It's never been in an indelicate location, thankfully. I'm not the best dermatologist, but I know when to refer someone for a skin problem. But I did have a question once. This made me realize that we should never take for granted someone's understanding about illness. For example, I had a question about strokes where people have decreased blood flow to the brain and it may injure the brain and cause neurologic symptoms like paralysis or inability to speak and so forth. The person asking me the question did not know that the brain was the place where strokes occur. And it seemed so obvious to a physician. So it kind of put me on notice to really be, descriptive and never take for granted someone's knowledge, lack thereof, or understanding about a disease state. It may seem humorous because most people probably in the audience realize strokes occur in the brain just like a heart attack occurs in the heart. But that was a instructive for me going forward as a physician. But I wish I had something more humorous, but I can't think of anything. How about you, Dr. Iyer?
I think the most maybe disturbing question somebody has asked me, and it might have been humorous in a different situation, but I was a resident at a patient in the ICU who we had just declared was brain dead, and we were going to be taking them off life support. And one of the patient's children was in there, in tears, appropriately, and the other child came to me and said, "Is there a mall nearby?" And just that really caught me off guard. So one of the most unusual questions I received at a very unusual time.
I have a sort of a similar story. It was a tragic situation as well in the intensive care unit where an individual had lost brain function from low oxygen. And the family was adamant that I refer their father for a brain transplant. And that I told them that that's not possible now. Maybe that's a future state. But again, these are, interesting questions that are very instructive about people's understanding or lack thereof about certain aspects of medicine. But we strive to be always respectful no matter what the question is. And Dr. Edwards has materialized.
What's up,
Hello.
Jenna? I bet you
So-
Melanie's been freaking.
I'm not freaking. I need to come back. So we are collecting questions. We were just talking about the questions that Dr. Iyer and Dr. Chaconas have been asked when sort of unexpectedly, either off the clock or on the clock, but out of context. Yes, in your glass you have wine, and on the plate you have sweets. So we knew you'd come back for both of those items. And those questions that have just been shared are a reminder that not everyone has the same baseline of understanding. And so in this session, there will be no judgment. You ask whatever you want to ask, and we will do our best to answer. So there are a few questions in the chat we could start from. Can you guys see that, or shall I read them?
Yeah, we can't see the chat box.
Okay. So the first one says, I have a question concerning an MCI diagnosis. What should the patient's expectations be with this kind of diagnosis? Is there a chance for Alzheimer's in the future?
Chuck, you want?
All right, well, so MCI is kind of an interesting diagnosis because it's very close to normal cognitive aging, that we all have certain deficits that occur as we age, just in the normal process. Mild cognitive impairment's defined, usually it's defined as amnestic, meaning that you have short-term memory issues, and that it doesn't interfere with the everyday details of your life. It is not upsetting. It doesn't change your capabilities. You might forget a few things, but it doesn't, and you're still able to lead a very normal life. 70% of the time, though, MCI will progress to some form of dementia. 30% of the time, it won't. We are very interested in the skills that it takes to deal with MCI and also early dementia. We feel like that patients can lead almost a completely normal life with MCI, mild memory loss, or early dementia, provided we recognize it and compensate for it. And so those strategies that we use to compensate for it can give us back a relatively normal life. So MCI doesn't disrupt your life. You still continue to lead a pretty much of a normal life, but it will progress 70% of the time to some form of dementia. Got anything to add on that?
No, I think that was good. I think mild cognitive impairment, in my experience in this practice, is the most common reason people come to our clinic. They notice a change and may feel like a little bit more than accountable for just aging alone. Just like Dr. Edwards says, maybe it's a bit more than aging. It's exceedingly common. I think usually in our early 70s, mid 70s is the average age when that might start to show up. It doesn't mean that the person is definitely going to, oh, I'm sorry, Dr. Edwards.
Damn,
It doesn't mean that
you're killing me.
it's going to be someone's destiny that eventually it'll turn into a dementia like Alzheimer's disease. But it puts us on notice, and these are the folks that we certainly want to follow longitudinally over time to measure and to anticipate the possibility that that person might decline and take on more and more symptoms that would meet the definition of a dementia. Because we're all about being ahead of problems, introducing care needs as they arise, and then getting ahead of safety concerns, particularly around driving and financial medication mistakes and so forth. So we take the diagnosis seriously. I think some people react to it better than others. I think it can be, at a minimum, annoying and frustrating, and it can be frustrating to family members as well if it's amnestic with memory issues. But everybody I've asked who has mild cognitive impairment, and when I say, if we could freeze you the way you are now and you get no worse, would you lead a happy life? And universally, they've said yes.
Yes.
I think part of that is in that they're hopeful they won't get worse.
we really want, one of the things that sometimes families are frustrated with us is when they come in, they've been dealing with some mild memory loss, and they want us to, make a diagnosis and sort of hit a lot of things hard. And what we're interested in at that point is their confidence. I want them to go out with mild memory issues. I want them to come out of the office with more confidence than they came in, because we, with a very few words, can destroy someone's confidence. And so reassurance that, yeah, we've got a little bit of mild memory loss, but in the big scheme of things, not a big deal. Okay. Now, sometimes families freak out when we say that, but that's where we're at. All right. What's next?
All right. We've got a couple questions about essential tremors. One is regarding essential tremors. Is there any research connecting dementia with essential tremors? And the other essential tremor question is, are there any meds for essential tremor that are not sedating?
So there's no definite connection between essential tremor and developing dementia. There are really two different circuits in the brain. People with essential tremor, many will develop the tremors very early in life. I think the youngest person I've diagnosed with ET was 7 or 8. It can actually start that early, and obviously you can identify a family history and whatnot. But there's no rule that says if you have essential tremor, it doesn't mean that you can't get dementia when you get to the right age. So there's not necessarily a connection between the two. It's just two coexisting conditions at the right age. Now, in terms of treatment of tremors, there are some medications that are not sedating. We typically start with medications that we call beta blockers that just gently lower your heart rate, because by reducing your adrenaline, it tends to reduce the tremors as well. Most people tolerate beta blockers without too much trouble. Some people do report fatigue, but most people do okay. There are a few other medicines we use, primidone or myceline, that can be sedating in some situations, but I like to dose those at nighttime because you sleep through the sleepiness, and you still can get some good tremor control during the day. Third line agents we use, there's a medication that's been used to treat a lot of different things. It's called topiramate or Topamax, and it's used to treat migraines. It's used to treat seizures. It's a mood stabilizer. At certain doses, it can actually be very effective to treat tremors. Other things that we do for tremor can include injections of botulinum toxin or Botox, as one of the versions is known. There are a lot of different wearables that are on the market now. It looks just like a watch that you wear for 45 minutes, and it stimulates the nerves in your arm, and it can mitigate the tremors for up to 90 minutes. It's called the Cala Trio, C-A-L-A. Trio, Trio, and it's something that many insurance companies will cover now, but it can be quite expensive if they don't. But a lot of different options, and not all of them are sedating.
Do you have to, you put a watch on and you keep it on for 90 minutes?
But you wear it for about 45 minutes, and then it gives you about 90 minutes of tremor control after you've worn it.
So if you're getting ready to tee off,
yes, you can wear it.
Yes.
An example
Can
is,
you get my insurance to cover this?
I can try. An example is a patient who's an orthodontist and wears it before procedures, and it works really well.
I'm talking about putting.
Yeah,
I get a little.
That's a procedure. It's
if my brain surgeon
you can wear it.
I'm not.
You can wear it up to 5 times a day. The risk is if you overuse it, you can get a little bit of burn, along the nerve tract.
90 minutes.
Thank you. That's pretty cool. Next one on the list is, a friend was diagnosed with aphasia. How can I help her? And I will apologize now if I mispronounce things, because I will.
Is your friend Bruce Willis?
I know that was sad. That let me take this because I've been thinking a lot about. It's funny because I've just got off the phone with a patient. All right, so let's be a little bit more specific. There are 3 types of aphasia. The first is expressive aphasia. What that means is that you know exactly what you want to say, but the words just don't come out. It's terribly frustrating. The patients always appear more impaired than they really are, because in real time, they know exactly what's going on. They can communicate, they can know when they're in family situations, they know their children, they know their names and everything. And then when it's their turn to talk, they just struggle to get it out. That's expressive aphasia. Receptive aphasia means that when the patient is being spoken to, you think they understand what you're saying, but they don't. Oftentimes it's a processing defect in the brain. And so either the end of what you're trying to get them to do is cut off, or the whole gist, they don't get it. And the third type is what's called semantic aphasia, which is devastating because it means you lose the meaning of certain words. For instance, someone might say, pass the salt. And you look and you say, what is salt? And where that really gets tough is, of course, when you lose the meaning of a word like love or devotion. And does it mean that you lose that emotion inside of you? That's an interesting question. So today I was talking to a patient who is presented 4 years ago with expressive aphasia. She didn't have a stroke, but it's progressed to where now she really struggles to get anything out. And so my counseling for her today was that we have to change our expectation about interfaces with other humans, other people. If someone has expressive aphasia and they're always going to judge the quality of the interface with another person by how well they choose words and communicate verbally, they're always going to be disappointed. They're always going to be crestfallen, and they're going to become more and more silent and mute. So what we have to do, first of all, is be upfront. Okay. So early on, what you say to someone when you meet them is, sometimes I have a little trouble catching the words, and I might struggle a little bit. Just be patient with me because I'll get it out. So therefore, you've got now the person you're talking to is an ally. They're on your side. But if you're struggling and they don't know, they're thinking, what's going on with this? This guy's not getting it out. All right. And so then I'm in a social situation, and I'm with my family. I've got my grandchildren around me. I've got my husband. I've got these people that love me. I can express love in interaction in different ways. It might be using touch, it might be hugs, it might be holding hands, it might be short bursts of verbal communication. But if I think that I'm going to give some sort of soliloquy to this family, I'm not. I've got to redefine how I interact with other humans. And I can use touch. I can listen. Music, we can share that. Smiles, facial expressions, all the things that are nonverbal communication. I even thought about how successful it would be if we could teach our patients to, in a very primitive way, to sign. They know what they want to say. Could they sign? So this is something that I've been thinking about because when you have expressive aphasia, the social stigma is powerful, and you feel like people are thinking that you're stupid, but yet you know exactly what you want to say. And other people are talking about politics, or they're making a bunch of stupid statements, and you can hardly wait to get in there to tell them exactly what they need to think of, but the words don't come. So we're working on this nonverbal communication. I don't know whether we can teach people to sign or not. What do you think?
I know. Yeah, I think it would be a challenge because, as you know, aphasia is not just the spoken word or receiving language and understanding. It's also reading and writing. And those things can be impaired as well. So it may be disappointing if someone wants to remedy or circumvent the problem with speaking by writing. Sometimes that's impaired.
Yeah, they
as
don't.
well.
Yes, and that's not the answer
Right.
of writing down. Now oftentimes they can't. They lose the ability to read too.
That's right. Yeah. The other thing, just a point of clarification, the Bruce Willis issue, when that came out, when they said he was diagnosed with aphasia, it's technically not a diagnosis, it's a symptom. And it behooves the physicians and certainly family members to seek the reason or cause. I think many people are familiar with the sudden loss of language from a stroke, and strokes by definition are a sudden neurologic symptom. But a gradual loss of language means something is slowly changing the brain, like from a dementia. And some people express Alzheimer's early on as purely a language problem, known as primary progressive aphasia. And others may get an aphasia as a later manifestation of the list of symptoms from Alzheimer's. Trauma can do it as well, brain tumors, hemorrhages. So it's not technically a diagnosis in and of itself. And technically, unless there's some sort of reversible lesion in the brain, it might not be, it might be out of the reach of treatment. To some degree, speech pathology or speech therapists can help, and it may be more strategies for improving communication, much like Dr. Edwards was discussing. But we'd have to prepare ourselves for a degree of frustration and not overpromise the remedies. So it's like you said, it's managing, it's coping with the condition.
In lowering expectations.
Yeah.
Okay, then thank you. The next question, I will certainly butcher the name of this, but please, it's comparing two drugs, Rytary to CLER, or are they the same and just one's generic and one's a name brand? RYTARY
So
and
Rytary, yeah, so Rytary, or the carbidopa, levodopa extended release, I think is probably what the question is pertaining to. So, you know, the mainstay of treatment for Parkinson's is to give levodopa. You know, levodopa goes into the brain and is turned into dopamine and replaces the dopamine that's missing. So there are a few ways to do this, and there's carbidopa / levodopa immediate release, which is called Sinemet, is the trade name. There's also a carbidopa / levodopa extended release, which is sort of a slower absorbing formulation. And then Rytary is also carbidopa / levodopa, and it's in the form of a capsule. And inside the capsule, there are 3 different crystals. A third of the crystals are immediate release Sinemet, a third are a delayed release Sinemet, and a third are a super delayed release Sinemet. So the carbidopa levodopa extended release or control release is different from Rytary because of the formulation. So they're not necessarily interchangeable. I'm not a big fan of the extended release or control release because the absorption is very erratic, and often people will take a dose and it never really kicks in, and then they may take the second dose and then they both kick in at the same time, and they can get a lot of abnormal involuntary movements. I do like Rytary a lot because it helps keep the levodopa levels pretty stable in the bloodstream. The challenge is it's expensive, and the insurance companies often make us try and fail the other ones. So my 2 main go-tos are the immediate release carbidopa / levodopa or Sinemet, and Rytary if the Sinemet doesn't work or gives side effects.
Thank you. The next question is a little bit practical and a little bit, I'm not sure the word. I'm curious about how to determine when it is the right time to consider a memory care option for my spouse. I've been wrestling with the idea that the Briar Creek Memory Center at the Barclay and South Park is new and not full, but if and when it fills up, what is the typical wait list for a quality opportunity in Charlotte? So do you take it while it's available or do you wait?
Well,
I think you're seeing the hesitancy because that's a common question that we deal with every day, and it's not a set formula or a recipe for this. And speaking personally from experience I had in my family, there's so many variables that lead us to act. I'm not sure that I would use the availability or the imminent availability of a place to push me to do it.
I would not.
Yeah, I know. And I know there's a lot of stress in our community. Luckily, our community has a multitude of options. I realize that we've been in a dark place with COVID, and there's been some variability in quality and turnover and risk. Some places have done better in warding off infection and so forth, but retention of quality people. There's so many variables that have occurred that hopefully are settling out now that we've come out of that sort of dark time. But the whole issue is, is it right for the caregivers, because we have to balance that decision with the impact of being a caregiver. And I think that's part of it. I mean, the notion that we should fall on the sword to spare a loved one the stress of making such a transition, that's a natural concern. And I think even myself, I have this, maybe it's a pie in the sky fantasy that I'm going to age so well, I'm going to die in my own bed in my house, and everything's going to be fine. But I think I think in a practical sense, we know that things as we age aren't always as we want, but those around us have to balance their own health, mental and physical health. And we should look for opportunities where the transition of someone to memory care could be not only a practical issue as a caregiver, but could also offer advantage to the person who's going to memory care. And in many ways, there are advantages, which we certainly should be discussing this with our families when they're here to see us. I'm not sure I don't want to overly simplify things, but I certainly want to hear what Dr. Edwards' position is on this, because it is definitely a hard decision and timing is difficult to determine.
We call it the decision. Okay, and the first decision that we deal with, of course, is when a couple who are together decide to go into a facility. What are the indications? What is it that makes that decision reasonable? And this is the second decision, is when you have to separate or make a decision for someone who now is alone and they need to go into a facility, and then where they go in. Now, 70% of people who go into a facility go in at the wrong level. Okay, so you have mom at home and dad's gone and she's not doing well. Okay, she's forgetting stuff. You go over there and you open a refrigerator and there's a bunch of bad food in there and everybody's behind the 8 ball. Now, I've been in this, everybody knows my story, both my parents but so they decide, okay, we're gonna take mom and we're gonna put her into a CCRC, but she's gonna need 2 bedrooms and she's gonna need this big place, because we're going from independent living at home to independent living there. That doesn't work, okay, because she's already gotten to the level where she's going to need at least assisted living. The indications for memory care specifically are wandering, incontinence, behavior, but wandering is a big thing, because if the patient is confused, and let's say they're at one of the facilities, and they're confused and they're in one of the public areas and they're looking around and someone comes up and says, "Miss Jones, how are you doing?" And she has no idea where they are, then the facility comes down hard, because they're going to say she can't be in independent living, or she can't even be in assisted living, because assisted living allows you to come and go. And here she is confused and getting ready to go out the door, and they are scared to death that she's going to get run over on Park Road. So there are lots of variables here. We like oftentimes for people who are in independent living, and if they're by themselves, here they are alone, and they spend most of the day alone. Now, during COVID, this was a disaster, because people in independent living, the facilities thought that they could manage their own medication, they could manage their own food. And what we learned very early on is they weren't taking their medication, they were dehydrated. And when they delivered the food, the staff was said, just ring the doorbell and put the food down on the floor, And so they would come and look out the door, didn't know that was their food. Then the staff is told, don't open up that because the virus is in it because the person's eating it. And so they weren't even eating. So the patients in independent living in these fancy CCRCs went right down the tube, okay, right down the tube. We had to call out there and tell them, guys, you got to wake up. We need more help because, again, 70% of them were in the wrong level. So we spent a lot of time, Eris is really good at this, of realizing where we are, what are the capabilities, and what is it do we need to make this situation when they start to lose a little bit still functional. We love smaller spaces. We don't need 2 bedrooms and a sitting room. They do better with smaller spaces. And they also do better when they have people around them, especially the staff. The staff in memory care that's staffed at a better ratio than in assisted living. Also, when you're in assisted living, when you go from independent, we like assisted living plus, where everybody's checked on in the morning. We make sure that they have their medicines taken on time, and then someone is always in the apartment when they're bathing. So we have certain things that we really like. I'm sorry to get so verbose here, but this is really important. And one of the reasons why every case is different. So we spend a lot of time in the office working with that.
Thank you. We have a question about sundowning syndrome, how a caregiver can best cope and prepare for that.
Alcohol really helps.
For who?
For the caregiver. Just kidding. Go ahead.
Sure. The sundowning is somewhat understood. I think if you've seen it, you know it. I mean, it's an issue that as the day grows long, someone changes, and it's usually an adverse change. So someone who is vulnerable to this, usually because they have a dementia, they may start out at their best in the morning, perhaps after a good night's sleep. But as the day goes on, you could almost liken it to using up your brain energy, and you don't have much reserve. So sundowning may be a misnomer because the sun doesn't have to be down, doesn't have to be dark for that. You know, I mean, it could be early afternoon. It could also be that someone's fine until they go to bed and then they wake up and they're going through a period of adverse behavior. That behavior varies. It can be subtle where someone seems to have misgivings and have some trepidation, a little anxiety. They may be restless. They could be inconsolable. They can also be prone to agitation and maybe even combativeness. However you look at it, they're suffering, and it makes everyone around them alarmed and suffering as well. And some people feel at a loss of what to do. I know that we seek a rapid remedy for this to protect someone from getting in the first place using medicines, or if they're amenable to taking medicines while they're under duress, although some people wouldn't take a pill when they're agitated, you might be inclined to give them something. But while medicines can be beneficial and effective and safe, and we always strive not to drug our patients. We don't want them to be impaired by the drug, which could be sedating and make their muscles relax and make them more prone to falling. These medicines can help, but we should also be analytical in looking for the triggers of sundowning and the things that are not medications that can remedy or ameliorate the symptoms of sundowning. And sometimes it's anticipating that sundowning could be coming, and then look to change the environment. Maybe it's a matter of the lights not being so bright in the room, or perhaps we need to illuminate the room better. The discussion, I was intrigued by what Dr. Edwards says, that in memory care or even assisted living, we might want a more contained environment with not too many rooms or options, because some people get sundowning because of doors that are open to other rooms that are dark. Just that sort of misgiving that there's another realm of unknown could be enough to trigger sundowning. Maybe it's shutting out noise from outside. Maybe it's playing soft music. Maybe it's creating sort of a custom where you're doing a day's cooling down, like after a workout you might do, where you're just trying to make sure there's not a lot of distractions. Maybe you don't want the TV on or a computer. Maybe it's soft music, quiet conversations. Maybe we are opening up photo albums and reminiscing, finding a place in the past where memories are best preserved that might be comforting, particularly about like wedding pictures or children or so forth. I think you understand where I'm going with this. There's no one formula and it won't work every time. And when someone's in distress, I think the only duty physicians have technically is to relieve stress and suffering. So we consider sundowning a form of distress and suffering. And if there's a way to relieve it with your efforts at finding ways to reduce the incidence or the severity of sundowning, and then our advice and our pharmacological interventions, we can usually get a handle on that. And I can give everyone hope. All the adverse behaviors of dementia don't have to happen in one person. They don't have to happen at all. They also don't have to persist. And, you know, there can be a rough patch, and you can hope that it's going to go away as dementia progresses. And it behooves us when we use medicine to always test to see if it's gone for good, where we remove medicines and say, hey, we don't need that anymore. But we certainly want to hear about sundowning, and we work through it.
One of the things that I like to, I really like rituals. And so let's say that at 4:30 or 5 o'clock, that the patient starts to be anxious. We can preempt that with medication. Sometimes I'll use it at 3:30, 4 o'clock, about 30 minutes before the agitation starts. I like to use low dose, and we can talk about the medicines that we use. But I like rituals. And so to have, it doesn't necessarily have to be a cocktail, but it can be wine, it can be tea. But I really like for the caregivers to read to the patient. There's something about being in the moment and reading a story. Now you say, well, they're not going to remember it the next day. It doesn't matter what they remember the next day. It only matters in their life what happens in real time. If they understand the story and can make a picture in their brain, it'll calm them down. So I really like that. And we've been successful probably, I don't know, maybe over half the time, but having structure and rituals. One of the things, a bunch of articles that melatonin helps. I've never seen it help. There was a whole slew of articles about 70% of the time melatonin is really good for sundowning. And I used it, and it was a joke. I mean, it didn't work at all. So I don't know who these people are that are writing these articles, but structure and understanding that this is programmed into us. When the sun starts to go down, we've always been fearful of the dark. And so it's kind of that preemption of those fears in us that have come from us for millions of years. And that's my simple explanation. We have lots of stuff we can do. I think Eris is right that today it might work and tomorrow it doesn't.
All right. Here's one that might be a quick one to answer. Dr. Iyer, this is for you. Can the Cali Trio device be used for PD tremors?
I will tell you that it works for PD tremors. It's not FDA indicated for PD tremors, so you may have to get your doctor to write the diagnosis of essential tremor on the order form, but it does work.
Okay. Let's see. This one, do we treat, the person says, I've been diagnosed with cerebellar ataxia, not hereditary. I see a specialist at Emory, but wondered if you could treat me.
Yeah, absolutely. And I think ataxia is a condition where ataxia literally means lack of order or lack of coordination. The part of the brain that's affected is the cerebellum. So movements can become very choppy, irregular, uncoordinated. The gait can become very challenging. The speech can become very challenging. It's all about symptom control and getting the right types of physical therapies or balance therapies or speech therapies, assisted devices at the right times. Sometimes we're lucky and some people respond to high doses of vitamin E. There's actually an ataxia with vitamin E deficiency that's been identified, and you can pretty much cure it with high doses of vitamin E. But I put just about every patient of mine with ataxia, I'll put on vitamin E in the hopes that they may get better. But absolutely, we're happy to help anyone who has that condition. And we have a number of patients here that do.
People on staff that.
Here's another one. Please comment on aphasia during Lewy body. My husband has lost the desire to eat very much and does not know the appropriate place to relieve himself. And someone in our practice mentioned aphasia.
Yeah, I think there's some of those aspects are not necessarily related.
It didn't make.
Yeah.
Are you talking about because aphasia would not? There's no. People can have speech issues with.
Not aphasia, apraxia.
Okay.
I'm sorry. We've got a typo in the chat. Apologies.
Typo.
Melanie has a
Sorry.
Yeah. This would be a good one for you.
Yeah, apraxia, APRAXIA. That's like it is like aphasia in the sense that it's a symptom or a sign. It's a sign we look for when we're looking for something in the brain that's not functioning real well. And if you look at the diagnostic criteria for dementia, apraxia is included, much like memory loss, much like aphasia, much like difficulties with reasoning and judgment, much like navigational skills when driving, which is a sign of visual spatial challenges where you may be able to see, but you don't process what you're seeing very well, including distances. So, but apraxia can affect different functions, different motor functions. And when we say motor, we mean movement. For example, in the dementias, as they progress, the part of the brain or parts of the brain for praxis, or the ability to do skilled motor acts, starts to weaken. So while you may have preserved strength and coordination to do something physical, such as walking, your brain may not be able to coordinate the proper movements. So you can develop a walking apraxia that we call gait apraxia. There often is a shuffling type of movement where we take short and slow steps and shuffle and don't swing our arms as much. But you can have also other difficulties with motor acts that are apraxias, such as simply knowing how to dress yourself, simply knowing how to feed yourself. So, ultimately, all of the dementias, because they're a degenerative condition of the brain where the brain in various places is losing ground. Quite literally, the brain is losing nerve cells and connections. Many of the dementias, as they advance, can look very similar. So you can have apraxias with many or most of the dementias. I think that early on, when we see people who are beginning to have dementias, there can be features that can help us discern between the types of dementia. Like it is often described that Lewy body dementia often begins with a little bit of Parkinson's motor symptoms, like slow movement or rigidity or tremor, and vivid visual hallucinations that can be quite alarming, in periods of inattention or sort of an absence, almost like being unconscious for the moment, and dream enactment where you thrash in your sleep during dreams. But as the dementias go on, they can share many of the symptomatology, including the apraxias. Now, just like Dr. Iyer was describing, where you can bring in occupational therapy or therapeutic interventions to help people mitigate the effects of these things, we can do that with apraxias. But sadly, as dementias progress, they outpace the ability of our therapies and interventions and assisted devices to help. So we have to anticipate and be prepared for that.
For me, apraxias are take us down a different road with dementia. An apraxia, just like Dr. Chaconas has said, is that it's the loss of a learned mode of movement. You used to be able to do it. It's like brushing your teeth. Okay, and all of a sudden the patient will look at the toothbrush and the toothpaste, and what do I do? Okay, that's an apraxia, the loss of praxis, motor function. So when you start to see apraxias, what I worry about is the loss of being able to use eating utensils and the ability to feed themselves. So it takes us down a certain way that we're going to go. So once they have that, one of the things about apraxia is early on, they can be cued, that you can take someone and say, oh, wait a minute, look, you've lost the ability to brush your teeth, but look, I'm going to brush my teeth next to you. Once they see you pick up they'll start to brush their teeth just like they always do. So apraxias can be cued early. But they lead us down this business of being able to feed ourselves. So when I start to see significant apraxias, I often have the fear that we are going to deal with the inability to feed ourselves or learn or know how to drink fluids. So they are really challenging, and they're just as challenging away from DLB, dementia with Lewy body. They occur with Alzheimer's, and they also occur with vascular dementia too.
I think what can be particularly challenging in people that have the eating apraxia, if you will, they won't know how to pick up the utensil and put it in their mouth. One of the challenges is that if you try to put the food in the mouth for them, they may not understand what they're supposed to do, and they'll pocket the food, or it'll just sit there, or they may choke on it later. So again, and sometimes with advancing dementias, the sign that people have lost interest or don't know how to eat anymore is sort of their way of saying, I might be ready to be done with this, and that's sometimes
but I had a funny thing the other day. So I don't know why, I grew up, I'm Roman Catholic, and every Friday we had to eat fish sticks. And so I always liked fish sticks. Okay, my parents would be eating lobster, and my brother and I are eating fish sticks. They were very cruel parents. A person comes in and says, Mom can no longer use a knife and fork and a spoon. So what do I do? And I said, well, let's go ahead and alter their diet so that they can have something they can eat. For instance, I really like soft things that are cut and that you can just eat with your hands. That's okay. We can't take them out to dinner. They can't go to the Palm anymore, but still tonight we can do it. And I said, fish sticks are particularly good because they're soft and you can pick them up and they're really good. So about 3 days later, the husband calls me and says, I just want to share, Dr. Edwards, the fish sticks is not really that good idea. And I said, why? She said, because my wife picked up, she said, I hate these damn fish sticks. Okay. So I like fish sticks. She's probably Protestant. That's a problem in and of itself. But so be careful of what you want. But the fish sticks didn't go over too good, but they actually would be good if you liked them. So if you have any Catholic people with apraxias, fish sticks are the deal.
Okay.
Sorry, Dr. Edwards. I'm Catholic and I hate fish sticks.
You hate fish sticks? Oh my God.
Probably had too many of them.
We have a lot more questions in here. You guys are great. Hope no one has anywhere to be. Are there any new memory drugs or trials you have patients participating in, and when might results be available?
I think, I think many of us heard about a year ago this June, that the FDA expedited the approval of a drug called Aduhelm or aducanumab. When you hear the word MAB or the letters MAB after a drug, it means monoclonal antibodies. So these are engineered medications or biological type medications that work through an immune mechanism. And for many, many years, there's been this belief that amyloid protein, many of you have heard of amyloid plaques, the plaques that form in the outer mantle of the brain called the cortex, and folks with Alzheimer's disease, that because that can interfere and degrade nerves and nerve function, perhaps if we can either prevent the accumulation of amyloid plaque or remove it once it's there, we might get a clinical benefit. Perhaps the patient will remember better, or maybe at the very least get worse slower. I mean, when we trained, amyloid was it. That was the theory. That was the bad thing. So this really spurred physicians or clinical investigators to seek a way to remove amyloid. It's a remarkable accomplishment that they found a way to take it out of the brain without surgery. So essentially they found an antibody, much like we produce in our immune system, that's engineered and injected. It finds its way to the amyloid and attaches to it, and your immune system then pulls it out of the brain. And with specialized PET scans called amyloid PET scans, you can actually measure the initial amount of amyloid in the brain, and then the benefit of I should say the ability to remove the amyloid. The value of those studies is that it made us rethink the amyloid theory of Alzheimer's disease. We know it's not good, and in some people, maybe if we can prevent its accumulation early on, there may be some benefit in warding off the disease or diminishing its impact. But it seems that in spite of successfully removing amyloid, even in mildly symptomatic folks with mild cognitive impairment from Alzheimer's or mild Alzheimer's itself, there is not a proven benefit. And the main question was, why would the FDA expedite the approval of the drug? They had a loophole where this came from the cancer world, where maybe there's a benefit if something major happens biologically. So maybe someone out there in the world of 25 million people with Alzheimer's worldwide, somebody could benefit from it. So let's get it out there, allow people the choice to try that drug. But the original company that they approved it for, Biogen out of Boston, was under and is under the obligation to continue studying it and to eventually deliver the goods that they've proven there is some kind of benefit. To date, they haven't. There has been some complications from the drug, including bleeding and swelling in the brain that can cause serious symptoms. It's not been affordable. It's been almost $60,000 for years infusions. So many of us are not happy with the whole amyloid theory. So there are other targets that are being looked at to actually impact the disease, because ultimately if we could prevent it from happening before symptoms occur, which would require identifying people destined to get Alzheimer's, or at least stop it in its tracks or reverse it or slow the progression, we'd get somewhere. Because the reality is 30 years later, we have no new drugs. They're the old ones you've all heard about, like Aricept and rivastigmine or Exelon and so forth, that are symptom medicines, meaning they don't impact the disease, but they can mask the disease a little bit and appear to slow the progression. In some, they may improve some order of function, perhaps memory, perhaps word finding, perhaps day-to-day organization. They tend to, if they're going to work, they may work best early on. So we still prescribe them. They do have nuisance side effects that are not serious. But the world of research, it is quite expansive. There are quite a few drugs that are on the horizon. Some are destined to improve brain metabolism and may give symptom relief. But suffice it to say, we're eager to get new tools. We're monitoring this. While we're not conducting research ourselves, we have partnered with several research organizations in Charlotte, and we're always looking for opportunities for those who are interested.
Yeah, I want to emphasize one thing, that one of the really benefits of our clinic is that Eris is extremely interested in all of these medications, all these clinical trials. He worked for Pfizer for 3-4 years. And so we have every day we're following this. So if something breaks and we feel like that it has value, we're gonna do it. But our principle, we have to protect our patients too, because so far on the amyloid theory and the monoclonal antibodies, the patients that got the drug did worse than people who were left alone. So we want to be on that. We want to be on that. No one wants this to work more than we do. But we have Biogen, they charged $56,000, and when it didn't work, they dropped it to 26. You got to be kidding me, okay? When it didn't work. All right.
All right. Next question. This person is wondering, the person that they're caring for is sleeping longer into the morning, seems to be getting worse, and sleepiness even during the day increases. In your opinion, should the caregiver wake up the individual to get them started or be more active?
No. All right, so there are 4 signs of decline that involve vital centers. And you'll see a pattern. The first thing you see is the patients are cold all the time, the temperature center. They'll be, you walk into a house of a person who's declining in dementia, you're going to sweat, okay? And one of the things that gets people sent into a facility is that the caregiver's tired of sweating all the time. They just want to get rid of this person. So cold intolerance. The second is appetite changes. What happens is that the signal from the stomach to the hypothalamus gets changed. In us, at least not in me, but in most people, when you've eaten a lot, the stomach tells the brain, you don't need to eat anymore, and it shuts it down. And then when your stomach is empty, the hypothalamus again engages it and says, it's time to eat. That goes. So if you put food in front of a patient who's declining, they'll eat it, but breakfast, lunch, and dinner, and that time interval means nothing to them, right? 70% of people will lose their appetite. They don't want to eat anymore. 30% of people, the hypothalamus keeps telling them, you've got to eat, and they'll eat everything in sight and they'll gain weight. And the third thing to address the question is that excessive daytime sleepiness is also a sign of vital centers being involved. The brain is kind of like a computer that if it's not stimulated and there's nothing going on, these brains can no longer entertain themselves. They don't have any psychic energy anymore. And as soon as they sit down, there's nothing going on, and so they will go to sleep. The fourth thing is you see all of a sudden someone has been spry. They've been gait has been energetic with energy, and then all of a sudden you look, and one day here they are shuffling. They're going slow. So those are 4 signs of vital centers being involved. Don't wake them up.
We've got 4 more questions. Let's see if we can get to them all. Let's see. What are some common treatments for patients progressing from MCI to dementia to anxiety disorder to disruptive episodes of breathlessness lasting 15 to 20 minutes? That does not sound like an easy question.
I could comment that I think we commonly use the term neuropsychiatric symptoms. If you think of psychology or psychiatric disease, there may not be a anatomical disease in the brain, but yet a person has anxiety or depression. A high percentage of our patients, by virtue of having dementia, have what we call neuropsychiatric symptoms, meaning the brain's degeneration is producing abnormalities in mood and behavior. The real common ones are apathy, depression, and anxiety. And I estimate that about 40% of the patients I see with dementia suffer from some degree of any or all of those things. And irritability is quite common as well. Going on to such things as psychosis with delusions and hallucinations and misperceptions and sundowning is not necessarily the destiny of all the patients. But I look at these folks and I'm always looking for the suffering that can be psychological. as a manifestation of their dementia. And I feel obliged to try to treat that suffering. And we're very careful with psychotropic drugs. These are drugs that modify brain chemistry and therefore hopefully give benefits in terms of brain, in mood and behavior, and sometimes improve cognitive functioning if we can ameliorate anxiety, which often derails concentration and memory. So we're looking early on to use these medicines. We tend to dose these medicines at milligram strengths that are quite low, and we slowly advance them because we know our patients are more sensitive to side effects that can occur from these medicines. And sometimes they don't even require the doses that a younger person may need for a similar mood problem. And I'm not sure I followed the other part of that.
Shortness of breath.
Shortness of breath.
I don't think that's
I think it may be a connection of, as these things
Anxiety.
progress, it's a form of anxiety. When people are nervous or anxious, the breathing becomes, there's very much like a sighing pattern to it. Some people actually feel out of breath when they're anxious. And you can put a pulse ox on them and it's normal. They just feel like they're breathless.
the
Anxiety.
The anxiety also can tip over into a lot of times our patients will describe fatigue. And you can imagine if they are really unsure of the context of their surroundings, they're anxious and the frontal lobe's not working to control that. And so they are constantly vigilant. They're constantly being stressed. And so they have profound fatigue. They just say, I don't have energy for anything. And that's the brain constantly stimulating the body, and they just run out of energy.
Thank you. We got an interesting question today by email. This one's for Dr. Iyer. Please explain the value or harm that eating fava beans 3 times a day might have, and should a patient try eating them if he's already on Cinemet?
I thought you were going to tell me that this was a Viagra question, which we often get. But
The fava beans have their own side effects.
But so fava beans they're a type of legume that is abundantly found in the Mediterranean areas. And so within the substance of the fava bean and even within the plant or the vine, there actually is levodopa. So there's levodopa inside the fava bean. And so again, the mainstay of treatment for Parkinson's is to give people levodopa. The problem is that when we give people levodopa to treat Parkinson's, we couple it with carbidopa, because if you ingest plain levodopa, your body's going to break it down and it's not going to get up into your brain. Roughly 1% of levodopa that you ingest by itself will actually make it to the brain where it becomes dopamine. So you would have to eat an incredibly disgusting amount of fava beans in order to get any kind of clinically relevant effect. That said, some people do feel like when they eat fava beans, it does help some of their symptoms. I think the thing you have to be careful of, it's not super common, but some people have a G6PD deficiency, which is a lack of an enzyme to break it down, and they can actually develop a life-threatening condition called hemolytic anemia if they eat fava beans and if they don't know that they have this enzyme. But in all seriousness, fava beans have levodopa in them. The problem is that plain levodopa won't go into your brain. You have to couple it with carbidopa.
But if you're already taking Cinemet and you added fava beans, could that be a dopamine agonist?
It could help.
There's an easier way to get that.
It could help the dose last a little bit longer. It might let a little bit more of it go into the brain.
But there are less gassy ways.
There are less gassy ways to do it, right?
Let's see. We've got 2 questions that we maybe could bundle together a little bit. This is something we could perhaps take care of on our Take Charge Live resource library. I would like a simple chart showing the levels of dementia and a correlation to levels of care. That would be useful. And the other question is that this person has noticed traumatizing events seem to trigger my mother's conditions, especially reading, writing, and verbal communications. Actually, I think that's the same person, and he would like a simple chart showing the levels of dementia and a correlation to levels of care.
Okay, we'll get back to them on that, but
Yeah,
we can provide that.
Very good
I don't know
idea.
how we do it.
All right. Well,
Also, our patients, especially as they advance, they love structure. They love repetitive days that are very similar. That's why I have only 20% of my patients travel well. Sometimes they travel well early on, and then later they don't. But the patients start to crave structure, intimate surroundings, familiar surroundings, closer walls. There's a security. As Eris really, it was really good, is that if they're in a place where there's 3 and 4 rooms, they don't know it's dark in there. They like that, and that's why, you know, sometimes we have to, you know, fight the families and say, oh, mom needs, you know, an extra bedroom in case my daughter from Spokane comes in. And I'll say, well, when is the last time your daughter from Spokane came in? Well, she's really never been here, but she might. So we're going to have an extra bedroom. So predictability and structure, repetitive schedules are very important. And what they do is they breed trust. And so when something happens, sometimes it's not the best thing to say to mom, who is, you know, in the throes of dementia. Say, Mom, what did you think about that bombing in Ukraine tonight? I mean, I think like 30,000 people were killed. That's not what you want to talk to mom about. Mom, you remember that trip that we took to York Beach, Maine that summer, and Dad got lost and how funny it was? That's what you want to talk about. But get rid of the atom bomb stuff, okay? All that is ambient anxiety. The more anxious they are, the less they are apt to control it. Also, I love the thing that when people come and visit their mother or father, and they come in, and I'll be there in the unit, and they'll go, "Hey, Mom, how you doing? What'd you have for lunch today?" Whoa, Mom can't remember what she had lunch any day. So asking questions about what's happened, all that does is create anxiety or confabulation. And she'll say, "Oh, we went to McDonald's." You know, they didn't go to McDonald's, or she didn't. So just be careful about what you're talking to them about, because anything that increases anxiety means they're not, if you're anxious, you're not going to remember. And if you're anxious, your speech is going to become impaired and stuttered. So just be careful about the words that you select.
thank you. I think we made it through all the questions that have been submitted. The last comments are all saying, thank you. This has been very informative, and it certainly has. Thank you so much. We really did it. 3 doctors, a little more than 1 hour, and a lot of questions.
Good job, Melanie.
My pleasure.
All right.
All right.
That was fun.
Good job, everyone. This is also a good opportunity to remind folks that on our website, we have what's called the Take Charge Online Resource Library, and many of the topics that were talked about tonight are actually addressed in that library. So if you haven't already, please take a look. Before we close up, I want to say thank you to all the doctors, of course, and thank you to everyone who's participated today. This was made by your questions, and we appreciate them, and we welcome them anytime, and we'll do this again. We also need to thank Southminster and Embrace Care. Thomas Brewer couldn't be with us tonight, but they are the sponsors of Take Charge Live and very good longtime partners of Memory and Movement Charlotte, longtime supporters. We're very happy to have just this month launched some hours at a satellite clinic, which is at Southminster and part of Embrace Care. And Dr. Edwards is there now once a week, and we will be following with other Dr. Hours shortly. So if you live at Southminster, thank you for joining us, and drop by the clinic. And that's all I've got. Thank you so much, and we hope to see you again next month.
Okay, everybody. See
Bye.
ya.
Thank you.
Bye now. Oh.